This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy network.
Welcome back to the podcast. In this episode, we're going to be speaking with Steve Bell around ethical and legal decision-making in pre-hospital care. So this is going to be the third in a three-part series on medical legal challenges within pre-hospital care. And it's really important just to get a real both focus and generic perspective on some of the issues within medical legal practice. So in this podcast, we're really going to focus on the ethical and legal decision-making processes that everyday clinicians face under various situations. So whether it's respecting the patient's autonomy, determining capacity, or indeed navigating complex end-of-life care scenarios, these decisions are often come with high stakes and also don't really have easy answers. So we're going to explore some of the key issues such as managing refusal of treatment, honouring advanced directives, and also addressing conflicts between ethical obligations and legal requirements. So we're also going to look into some real-world case studies that Steve has navigated in the past and just really unpick the learning from that. So today we're joined by Steve Bell. Steve is an NHSConsultant paramedic. He's also a consultant HEMS paramedic with extensive experience in pre-hospital care across ambulance trusts and HEMS services. He is also a published researcher and educator. Welcome to the podcast, Steve.
Thanks, Alan. Yeah, it's great to be here. I'm delighted to be invited and hopefully we can have a decent conversation.
Oh, it's fantastic to have you, actually. Let's kick off, Steve, by just really digging into maybe from your perspective, some of the fundamental issues you see within pre-hospital practice within the medical legal domain as a recurrent theme. Could you speak to some that you've seen throughout the longevity of your career?
I think when it comes to medical legal cases or even regulatory cases, probably the biggest theme that comes out is the classic documentation, really. So it's always standards of documentation, or I guess more specifically when it's got to legal cases or regulatory cases, deficiencies or omissions in documentation or inaccurate documentation. So almost without doubt, every kind of case starts with a query around documentation or questioning documentation, or by implication questioning the interaction that the clinician had with the patient by virtue of what is on the clinical record, or perhaps significantly not on the clinical record. And that's a theme, I think, in almost every case I've ever dealt with or been involved with or been asked to comment upon, really. So that's probably a good place to start our conversation.
Absolutely, indeed. And as you said, it's I guess the documentation domain is difficult for a number of reasons, because like we've spoken on the podcast already, if it's not documented, it's really difficult to prove it actually happened in practice. And that's one of these fundamental baselines which we really want to capture as much information as possible for every patient. Could I get you to speak to how we do that in practice? So just documenting, balanced clinical judgments and also, respecting patient autonomy, because it is different. I mean, we all know the pre-hospital environment is a difficult environment. It's dynamic, it's changing. Would you advocate just documenting as much as possible, and indeed the surrounding circumstances as to why decision making might have changed, or indeed the environment changed, or the presentation changed? What would be your approach in some of these complex and ever changing situations?
I think you've summed it up quite nicely there, in the sense that it's actually really quite complicated, isn't it? The nature of pre-hospital practice, the nature of the work we do is multifaceted, it's multi-changing, it's different environments, it's complex environments. And it's really hard to kind of give a baseline or a benchmark of what should be included, what shouldn't be included, because there's just such a variety of presentations and patients. But I think there is things you can do to kind of protect yourself against that. I think as a profession, we've perhaps migrated more towards what's the medical model of record keeping. So having a very structured approach to your records. Listeners will be familiar with, starting off with present and complaint, history of present and complaint, on arrival, on examination, findings, plan, all that sort of stuff that will be familiar to people who listen to this podcast. And actually using that as your basis to kind of make sure your records are consistent, that using that model, it means your record keeping is repeatable. It means in those high stress, high intensity environments, you have a structure to work to, you're not missing key elements out. And I think that's probably the first tip. And it's not obviously my tip, it's kind of well educated and well taught these days, but having a structured approach to record keeping can definitely be the thing that gets you out. How much you put in a record, that's that how long is a piece of string question, isn't it? That has got to be a professional judgment by the individual clinician. I suppose it's a little bit Goldilocks almost, isn't it? Not too much, not too little. You have to hit that sweet spot. And I think probably one of the things we'll talk about is omissions in documentation, which I think from my view, especially when you get into these kind of medical, legal, regulatory cases, it's the stuff that's missing from documentation, which can be pretty important.
Let's just dip into capacity and consent, if that's okay with you, Steve. And maybe if I could just get you to speak to your approach, or indeed some of the framework in your mind you go through when you're assessing a patient's decision-making capacity in the field.
Again, I think this is something we've made quite good strides on in sort of certainly UK practice anyway over the last few years. I don't think assessing capacity is new to clinicians anymore. It's become pretty well grounded. It's obviously dictated by acts of law, and I think clinicians are quite familiar with doing that functional capacity and all the rest of it. I think the thing that troubles me, and we see quite often, is that the concept of informed consent. So assessing capacity is a first start, but actually in order for a patient to provide consent for an intervention or a refusal of intervention or refusal of transportation, it has to be informed. And if we go back to documentation and sort of omissions in documentation, then quite often we see no evidence that the patient was given the full picture, the balanced picture, that they had all the information that is required under the Medical Capacity Act in order to make the decision they've made. So for me, it's almost less about how well or how poorly we do a capacity assessment. And actually, once you start digging into it, well, actually, have you given the patient sufficient information to make the decision that they've ended up making or that you've ended up asking them to make?
Yeah, I couldn't agree with you more, actually. And like you said, it's also, I guess, the fruition of that decision, the consequences, but also the consequences of their decision, even if it's an unwise decision. I think we spoke about on the podcast about respecting the patient's unwise decision, which is actually quite difficult, but it's prudent to do so. But could I get you to speak to refusal of treatment and or transport? So if they lack capacity, that might be one avenue to go down to make an informed decision. But could you get you to speak to what you see both within the service you work and generically about documentation around refusal to transport?
Refusal without capacity is probably an easy process or an easier process in that, there are quite clear guidelines around it. As you've just alluded to, it's that refusal with capacity, which we perhaps perceive as being an unwise decision, which is always the difficult one. And quite often they are the ones that come back because the patient ends up having an adverse outcome, and then they come back looking to get some follow-up, I guess, on why they've had their adverse outcome. And this is when we come back to, well, were they actually informed to make the decision they made? And particularly that's around the risk of deterioration or the risks and the consequences of not getting the treatment that's been advised or not getting the assessment that's been advised. And again, I think as clinicians, we probably do it, but we loop right back around to the start of, well, do we capture that on a documentation? Do we actually write down the advice we provided? Do we write down the risks that we've exposed the patient to or that we've informed them of? And is that in 6 months' time, 2 years' time, when it gets dragged up and the case comes along, is that there as part of the clinical record? So that would be the bit that I would perhaps emphasise. Again, less around do they or don't they have capacity, but more around what you've done as a clinician to ensure they've made an informed decision.
No, indeed, indeed. Could I get you to speak around the ethical and legal considerations when treating unconscious or incapacitated patients? So either reduce consciousness through drugs or alcohol, without clear consent. Again, would that be hanging on very much a Good Samaritan Act, or indeed on good, clear, concise documentation and decision making, just evidence of such that you're working in the patient's best interest? How have you navigated that with crews before, indeed seen that in documentation?
I'll use the word easier, which is perhaps the wrong word to do, but I almost think that's easier because we obviously have the concept of implied consent. And as you've just touched upon there, acting in the patient's best interest. So if they are truly incapacitated, they are truly unconscious, then again, the Mental Capacity Act makes provision for that. And it's almost easier for the clinician to identify that, to act upon that. And I don't like the term, but it's almost more defensible further down the line because you have essentially, a concrete situation where the patient was incapacitated, as long as you've accurately documented that they were indeed incapacitated, and also that that's substantiated by other sort of forms of evidence, witness statements. So I think that's probably less of a challenge. The challenging ones are the ones we've already touched upon, where it's that unwise decision that we go back to it, and where there's probably that massive area of grey around, does the patient have capacity? Do they not have capacity? How intoxicated are they? Are they very intoxicated, a little bit intoxicated? Is that affecting judgment? Is that affecting their retention of information? I think they're probably the challenging ones.
Could I get you to speak to, let's pivot slightly and look at end of life care, actually, and advanced directives. This can be a bit of a minefield, I guess, for clinicians in a number of regards, because they, as far as I'm aware, they need to be, and I could be wrong, but they need to be written down, or at least explicitly documented for the clinicians to be able to honor them. But could I get you to speak to your take on how clinicians and crews ensure they respect advanced directives, or DNAR, do not attempt resuscitation orders during emergencies? Because we do know that sometimes documentation isn't front and foremostly available when there is a declared emergency, and it can be difficult for clinicians. Could I get your thoughts?
Well, firstly, I completely agree. We quite often see this coming up through various sort of senior advice challenge and looking senior advice channels and looking for input on these sorts of decisions where documentation isn't immediately available. I think without kind of ducking the question, it's probably really important clinicians work to organisational policy and procedure around this, because I think there is variation around the country in terms of what's actually guided. I think as an overarching principle, I think as a sector, we're transitioning to, if you have reasonable belief that the documentation exists somewhere, but perhaps isn't with the patient at that particular point in time, then you have a degree of backing. But again, I wouldn't like people to go and act on my word on this podcast for doing so. I think it's prudent that you check out the local situation. But I think we have moved away from the position of you must have the bit of paper in your hand to a reasonable and honourable belief that it is in existence somewhere. So the patient's collapsed in the street, but the documentation's in the house would be a sort of classic example of that.
Yeah, absolutely. And I think to your point around validity, it's prudent to see it, but also have a shared decision-making process whereby there is maybe a baseline of care until the documentation is provided. Then you can step up or withdraw that not necessarily the care, but the treatment. I think that's a fundamental point as well, is it's not removing care from a patient, because the care is actually extended to family members as well. And actually, in giving someone a maybe a peaceful death, if that is the advanced directive, actually it's the care is actually the first and foremost thing you need to do for the wider family. It's more guiding the treatment, I think. I know it's semantics, but it's easy to fall into this actually withdrawal of care principle.
No, I don't think it is semantics. I think it's subtlety in language, but you're absolutely right. Treatment or intervention is very different from offering care to a patient, whether that's emotional or psychological care. And as you say, to the people around them. I think the other thing you can do is, and again, you've started to allude to it, is actually what other steps can you take to satisfy yourself of records being available? So, we're getting increasing access to shared records online. You can look there, you can make contact with the patient's GP, you can have conversations with community Macmillan style nurses, short of actually seeing the piece of paper in your hand, I guess.
Steve, could I get you to speak to, I'm sure you have had to navigate, as have I, a few very difficult ethical decisions when there is a terminal diagnosis or indeed prognosis, and there's maybe the fruition of that diagnosis on scene, but there's really a lack of acceptance from family members. And so you've got this disparity of family expectations and but then maybe clear documentation from a GP, like you said, shared online records from what is very clear diagnosis. And sometimes clinicians, I think, can be caught in the crossfire between and knowing what to do. Could I get you to sort of speak to how you approach some of these difficult conversations with families, balancing expectations, trying to come to the best outcome? I've certainly had been caught in the crossfire a number of times, and I've had to rely on that shared decision making and reach back, but very much a plenary approach. But could I get you to speak to some of the occasions when there has been disparity that you've encountered?
So again, I think this is probably one of our more challenging areas of pre-hospital practice. The ambulance service, again, certainly in the UK, quite often is the fallback point for when community services or when GP services aren't available, and 999 becomes the call. And you're right, our pre-hospital paramedic, EMT clinicians end up in exactly these situations, and it's really difficult because that's not the sort of essential purpose of the ambulance service to be managing these situations. I think quite often it's about managing the people. It's about managing the reaction. Probably sadly, not always, but conversations have happened with the family. There is a plan in place. They have had conversations with senior doctors, GPs, and all the rest of it. And it's just at that point in time when it's a crisis mode that they become unaccepting of it, or emotion takes over. I think you're absolutely right here. I think I would absolutely advocate sharing that burden, if you like, sharing that decision making. And I don't think it matters, what grade of clinician you are. You probably have access to somebody just to double check you're thinking, and just to double check that you're doing the right thing. And quite often, and by virtue of doing that, that can become reassuring for the family. It's not just you standing in their front room who's saying that. There is somebody else who's also supporting that decision making. But ultimately, the nature of the work we do, sometimes you just get caught in a very difficult situation, and there may have to be compromise to be made. But I think we have to strive more and more as a sector, as a profession, for the dignified death, for doing the right thing by the patient, and trying to achieve that even in these really highly charged, emotional, and certainly sometimes tense and even hostile situations.
In a way, Steve, I'm in danger of answering my own question, but I just wanted to ask you, how clinicians should then navigate this from a document perspective. I totally agree, and I think shared decision making is absolutely key in these decisions, in these difficult circumstances. Would you advocate sort of robust documentation from the team, but also the record? I think, if I'm right in thinking, the phone calls that you do make to reach back services, so to an on-call service, is also recorded. Voice calls to EOC, the Emergency Operations Centre, is also recorded. So is it almost getting this collection of various modalities of communication documented just to make sure it's a robust and indeed shared decision from the team?
So you are in danger of answering your own question. I think, yes, I think we almost have to be careful not to be trying to become too defensive in our practice, and not to practice defensive medicine just in case we get caught out. But then absolutely, you have an obligation to document accurately, clearly what's happened and what the process has been. And that should also include, I had a conversation with GPX, or I had a conversation with senior clinician, whoever, and the nature of that advice. And I would advocate and, to a degree, expect that that does form part of a clinical record. So whereas you're absolutely right, there will be other forms of evidence of that conversation having taken place. I think it's very prudent that clinicians who are essentially making the decision, or certainly the face of the decision, are including it in their own individual clinical record, and within that patient record, that's the process we went through to get to the outcome we did. And it wasn't, taken lightly, and it was a fairly robust and, as you say, shared decision. So,
Steve, I wondered, as we're starting to come into land in the conversation, could I get you to speak to just one or two case studies, really, from your top of mind that really that I guess in a way reveal and or showcase some really tricky decision making, but also how you've navigated those ethical and or legal decisions on scene, and how it was indeed resolved?
So yeah, I'm slightly reluctant to just talk about specific case studies because obviously there are individuals involved in that. But certainly the theme comes back to, you know, and I'll say omissions in documentation, which is a fairly sort of harsh statement, but I go back to documenting the things that have happened but are not necessarily hard clinical findings. So almost every clinical record will have physiological observations in it. Almost every clinical record will refer to that. Not many clinical records have an explanation of differential diagnosis consideration. Not many clinical records have information around pertinent negative findings. And as we already talked about, not many clinical records refer to the process of informed consent that we went through the patient, the information we give. So I think if clinicians want to enhance their standard of documentation, as well as the sort of hard physiological, factual medical findings, think about the stuff that is almost harder to quantify, harder to write down. But certainly when it comes to, whether it's cases of patient refusal or whether it's cases of actually non-conveyance, they're the two that sort of frequently come up during medical, legal, or regulatory cases. Have we really thought about documenting the entire picture and essentially the entire consultation, which really does include that bit at the end around why the patient has ended up hasn't ended up in ED or has ended up not being referred? I think I've kind of ducked the question a little bit there, but I think that would be my sort of general take advice without getting into specifics.
No, absolutely. And I think that's still extremely relevant. And as you said, it's the wider considerations, it's attention to detail around the whole consultation and the actual circumstances of that consultation. Other, like you said, side conversations, which can be quite central still because they can inform decision making and they can inform the wider team. And so I think you're absolutely right. It's about capturing everything as meticulously as possible, especially in the complex cases. Steve, could I just get you to speak to some take-home messages, really? Everything you've spoken about actually is fantastic, and I think the real challenge from my side is being consistent at 3 a.m. or 4 a.m. on the fifth night shift at the weekend when you've got that super difficult case, you're fatigued, you're tired, but actually still mandates the same level of compliance and attention to detail. And I think that, from my perspective, that consistency is king in documentation. But could I get you to speak to some take-home messages for listeners from the conversation?
I think if we try and understand the purpose of clinical documentation, that's really useful. So, as an individual clinician, potentially as a registered practitioner, you have a professional regulatory obligation to maintain good clinical records. So you should be doing that. I think we all understand that, but as you've said, sometimes at 4 a.m. or on the 12th job of the shift, that's quite difficult. I think an understanding of why we generate a clinical record, so that enhances patient care. It allows handover of care, allows handover information. It forms a long-term part of the patient's record, which is potentially useful when something changes in 6 months' time. And then I think an appreciation that, again, without advocating defensive medicine, that in a lot of medical, legal, or regulatory cases, documentation is almost a starting point for the case. And it's the starting point where people look at it and they start to pull holes in it and they spot omissions. And that's where the whole process stems from. So actually, robust documentation will protect you from that. I won't say defend you from that. It'll protect you from that. I would also say as well that, I think you mentioned it right at the beginning, the old adage that if it wasn't written down, it didn't happen is not too bad a basis, but actually isn't completely truthful. The clinical record isn't the only piece of evidence that's taken into account. But as I've said, it's often the catalyst for cases to be taken forward. And it's often a critical piece of evidence that people rely upon. So I think, ensuring that, and we've talked about it in terms of a structured approach, a approach that you can replicate, that you can remember at 4 a.m. or after the 12th job or in the high pressure situation, that you're documenting those same things every time. It becomes routine for you. And then, yes, please remember that slightly sort of softer stuff around pertinent negatives, differential diagnosis, informed consent. And then if you manage to do all that on your fifth night shift at 3 a.m., then, you should be standing in good stead, really.
Steve, thank you. It's fantastic just to get your thoughts actually, and like I say, really get your bump up against some of your experiences because, like you said before, through the longevity of time, multiple circumstances, sometimes these incidents can really catch you out. So it's great to get your thoughts and ideas. So thank you.
No, you're very welcome. It's great to talk to you. Thanks once again for the invite.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.